This lecture is going to go over adrenal gland hypofunction. So if you think back to your assessment of the endocrine system lecture, when we talked about the adrenal cortex, what were the two principal hormones associated with the adrenal cortex? And hopefully you're able to pull out cortisol and aldosterone. So that's what we're going to be talking about in terms of adrenal gland hypofunction, is inadequate amounts of cortisol and aldosterone. Adrenal corticosteroid production may decrease as a result of many things, including inadequate secretion of ACTH, dysfunction of the hypothalamic pituitary control mechanism, or direct dysfunction of adrenal gland tissues. Symptoms may develop gradually or occur quickly with stress. An acute adrenocortical insufficiency, also known as adrenal crisis, life-threatening symptoms may appear without warning. So again, with adrenal gland hypofunction, there's a loss of aldosterone and a loss of cortisol action. Decreased cortisol levels result in hypoglycemia, gastric acid production, and glomerular filtration decreases. Decreased glomerular filtration leads to excessive BUN, or blood urea nitrogen levels, which cause anorexia and weight loss. Reduced aldosterone secretions causes disturbances in fluid and electrolyte balance. So normally aldosterone's job is to hold on to water, that makes the body hold on to water and sodium and causes the body to excrete potassium. So with adrenal gland hypofunction, we have reduced aldosterone, and that leads to sodium and water being excreted. So sodium and water excretion are increased, causing hyponatremia and hypovolemia, and potassium excretion is decreased. So the body's going to hold on to potassium. Low adrenal androgen levels decrease body axillary and pubic hair, especially in women. Acute adrenal insufficiency, also known as Addisonian crisis, is a life-threatening event in which the need for cortisol and aldosterone is greater than the body's supply. So again, with this hypofunction of the gland, we need more cortisol and aldosterone than is available for the body to use. It often occurs in response to a stressful event such as surgery, trauma, or severe infection, especially when the adrenal hormone output is already reduced. Problems are the same as those with chronic insufficiency, but are more severe. However, unless intervention is initiated promptly with Addisonian crisis or acute adrenal insufficiency, sodium levels fall and potassium levels rise rapidly. Severe hypotension results from the blood volume depletion that occurs with the loss of aldosterone. You have a chart in your textbook, chart 62-6, that lists emergency care of the patient with acute adrenal insufficiency. The three things we're addressing are hormone replacement, hyperkalemia management, and hypoglycemia management. So please review that table on your own. Addison's disease can be classified as primary or secondary. Primary cause would be a problem with the adrenal gland itself. A secondary cause is a problem with something other than the adrenal gland. So it could be the hypothalamus, pituitary gland, drug-related. A common cause of secondary adrenal insufficiency is the sudden cessation of long-term glucocorticoid therapy. Glucocorticoid therapy. This therapy suppresses production of glucocorticoids through negative feedback by causing atrophy of the adrenal cortex. Glucocorticoid drugs must be withdrawn gradually to allow for pituitary production of ACTH and activation of the adrenal cells to produce cortisol. So basically, when a patient is taking a steroid and then that ending in SON or Solone and it's long-term high dose, the adrenal gland quits doing its job because it's getting that steroid from an external source. The body's getting, its needs are being met. And if a long-term high-dose glucocorticoid therapy gets stopped, the body needs suddenly. The body doesn't have time to adjust, right, to turn back on, to get adjusted back to what it needs to be producing in terms of cortisol. So the reason that you see a lot of those NCLEX questions that talk about tapering down steroid doses and weaning people down is because we need to do that so that there's not a sudden decrease of glucocorticoid in the blood when the adrenal gland isn't ready to produce cortisol. In terms of assessment, ask about symptoms and factors that cause adrenal hypofunction. Ask about any change in activity level because lethargy, fatigue, and muscle weakness are often present. Include questions about salt intake because salt craving occurs with hypofunction. Chart 62-7 lists key features of adrenal insufficiency for you to review on your own. GI problems include anorexia, nausea, vomiting, diarrhea, and abdominal pain. Ask about weight loss and changes in menses. Ask men about impotence. Ask whether the patient has had radiation to the abdomen or the head. So why are we asking about abdominal radiation? If you remember where the adrenal glands are located, right? They can get exposure to abdominal radiation because they're located right above the kidneys, and that can affect their function. Cranial radiation could interfere with hypothalamic or pituitary influences on adrenal function. Document medical problems such as TB or previous intracranial surgery and all past and current drugs, especially steroids, anticoagulants, opioids, and cancer drugs. Symptoms of adrenal insufficiency vary, and the severity is related to the degree of hormone deficiency. In patients with primary insufficiency, which is the problem with the adrenal gland itself, plasma ACTH and melanocyte-stimulating hormone levels are elevated in response to the adrenal hypothalamic pituitary feedback system. Anything that stimulates increased production of ACTH also leads to increased production of MSH, or melanocyte-stimulating hormone. Elevated MSH levels result in increased pigmentation. In primary autoimmune disease, patchy areas of decreased pigmentation may occur because of destruction of skin melanocytes. Body hair may also be decreased. In secondary adrenal insufficiency, problems in the hypothalamus or pituitary gland leading to decreased ACTH and MSH levels, skin pigmentation is not changed. Assess for hypoglycemia and fluid depletion. Hyperkalemia can cause dysrhythmias with irregular heart rate and result in cardiac arrest. Hyponatremia, leading to hypotension and decreased cognition, is often one of the first indicators of adrenal insufficiency. Depending on the degree of imbalance, patients may appear lethargic, depressed, confused, or even psychotic. Assess the patient's orientation to person, place, and time. Families may report that the patient has wide mood swings and is forgetful. Chart 62-8 has the lab values that you need to know for hypofunction of the adrenal gland. And if you look at those lab values, they talk about sodium, potassium, glucose, calcium, bicarb, BUN, and cortisol. And with hypofunction of the adrenal gland, you know cortisol is what? Is it high or low? Cortisol. Hopefully you're saying low. We're talking about hypofunction of the adrenal gland. That would be low cortisol. So if you look at those lab values, you have low cortisol. You also have low sodium, so hyponatremia. And then the other one would be glucose is normal to decreased. So if you can remember those three together, all the rest are increased. An ACTH stimulation test is the most definitive test for adrenal insufficiency. ACTH is given IV, and plasma cortisol levels are obtained at 30-minute and 1-hour intervals. In primary insufficiency, and remember primary insufficiency is a problem with the adrenal gland itself. After giving the ACTH and then monitoring, the cortisol response is absent or very decreased. So they give the ACTH, but there's no response from the adrenal gland, letting us know that it's a primary insufficiency. The adrenal gland itself isn't functioning well. In secondary insufficiency, it is increased. When acute adrenal insufficiency is suspected, treatment is started without stimulation testing because, again, acute adrenal insufficiency or Addisonian crisis is a life-threatening event. And again, chart 62-6 has the emergency care for a patient with acute adrenal insufficiency, starting with hormone replacement. We give them some fluids. We get glucocorticoids on board for them. And then it also talks about hyperkalemia and hypoglycemia management. Nursing interventions focus on promoting fluid balance, monitoring for fluid deficit, and preventing hypoglycemia. Because hyperkalemia can cause dysrhythmias with an irregular heart rate and result in cardiac arrest, assessing cardiac function is a nursing priority. Assess vitals every 1 to 4 hours depending on the patient's condition. Weigh the patient daily and record I's and O's. Monitor lab values. Cortisol and aldosterone deficiencies are corrected by hormone replacement therapy. Hydrocortisone collects glucocorticoid deficiencies. Glucocorticoids, again, you recognize by that SON, SON, or SOLON ending. Oral cortisol replacement regimens and dosages vary. The most common drug given is prednisone. Generally, divided doses are given, with 2/3 given on arising in the morning and 1/3 at 6 p.m. to mimic the normal release of hormone. You have a drug alert box in your textbook. Prednisone and prednisolone are sound-alike drugs, and care is needed not to confuse them. Although they are both corticosteroids, they are not interchangeable because prednisolone is several times more potent than prednisone, and dosages are not the same. An additional mineralocorticoid hormone, such as fludrocortisone, may be needed to maintain or restore fluid and electrolyte balance. Dosage adjustment may be needed, especially in hot weather when more sodium is lost because of excessive perspiration. Salt restriction or diuretic therapy should not be started without considering whether it might lead to an adrenal crisis. So here's some visuals for you. Again, when you hear Addison's disease, you should be thinking adrenal insufficiency. So adrenal gland hypofunction, the same thing as Addison's disease. And this image here says add hormone to treat Addison's. And I've heard even more specific, add a SON, like ADD or plus sign add a SONE as a reminder as to how we're going to treat Addison's disease or adrenal insufficiency by adding an SONE drug, adding a glucocorticoid, right? Because that's what we're missing. I've also heard someone say add a SON, add a salt. So add an SONE and also add a salt, which helps us to remember that the patient is hyponatremic with Addison. And here's another visual for you for Addison's disease and some additional information about adrenal crisis. Also known as acute adrenal insufficiency or Addisonian crisis. That's that emergency condition where there's not enough cortisol and aldosterone in the body to meet the body's needs.